Hello, everyone. We have a short case for discussion today. It's a case of cardio-renal syndrome, and it would be an interactive clinical case based discussion with Dr. Rania Omar. She is an ICU consultant in Abu Dhabi, and we have Edoardo Terzolo, who is a nephrology resident in Italy. So we have diversity here between Europe and Asia, and also between nephrology and ICU physicians. So our case is a 35-year-old male patient with a history of advanced congestive heart failure with ejection fraction around 35. And he was admitted to the ICU with worsening volume overload and AKI, so typical cardio-renal syndrome. He was sedated, ventilated. He was hypotensive on 0.2 mics per kilogram per minute of norepi. And over the last 48 hours, his urine output was declining. And now he's only producing about 20 cc of dark concentrated urine. He has AKI was rising creatinine up to 6.7 from a baseline of 1.4 milligram per deciliter. Now his BUN is 140, and his oxygen saturation is 92% on 50% FiO2. And this is his chest X-ray, the most recent one. And here is our first question, and I think ladies comes first. So let's start with this question, and I will allow Dr. Rania to read the question and to try to answer this quick question.
So, hello, Dr. Amr, Dr. Edoardo. I'm very happy to be with you today. Let us start with the answering of with this question following the case. Which of the following statements regarding dialysis modalities is incorrect? Choice A, studies comparing extracorporeal ultrafiltration with diuretic therapies have conflicting results. If there is a substantial need for solute clearance, chronic kidney replacement therapy would be better than intermittent hemodialysis. PERT, a prolonged intermittent renal replacement therapy, is a hybrid hemodialysis modality that is longer than the conventional hemodialysis and offers diffuse solute clearance and a slow ultrafiltration. When the goal of kidney replacement therapy is solely volume removal, SCUF, slow continuous ultrafiltration, would be the option of choice. And number E, regardless of the modality of kidney replacement therapy in cardio-renal syndrome patients, the mortality rates remain very high. These are the five options that we have for the question.
Which one would you pick? So remember, you are choosing the incorrect one. Which one would be incorrect?
Which one would be incorrect? I would suggest, let me read my mind out loud. I don't know if this is studies, again, comparing extracorporeal conflicting results. I think, to my opinion, is answer A. I don't know.
You think that there is really studies that showed
they don't,
differences between diuretic and ultrafiltration?
This is the incorrect answer, right?
Sure,
they don't have conflicting results, right? They don't have conflicting, both of them.
You think all the studies have consistent results?
Consistent results, meaning that they all show good mortality. This is what is meant, but this is all show good benefits from the ultrafiltration, right? Just let me take another look. there is a substantial need. Type we can we can remove just a
Okay,
moment.
that should be fine. So thank you again for trying to answer this question. And here is the right answer. So choice B is the incorrect one because they mentioned that if there is a substantial need, so if there is significant need for solid clearance, in cases like hyperkalemia or severe uremia or severe acidosis, CRRT would be better than intermittent. Of course, this is wrong. It's not unusual actually to start, couple hours of intermittent HD before starting CRRT just to get better clearance, because it's low continuous therapy from its name. It takes longer time. So if the patient has severe hyperkalemia, EKG changes of hyperkalemia, you don't want to wait for 6 or 8 hours or 12 hours for this electrolyte imbalance to be corrected. So you usually try to start a couple hours of intermittent HD if the patient can tolerate, then you switch to the CRRT. For the first option, option A, it's actually correct. Several trials evaluated the clinical impacts of extracorporeal UF and compared it with diuretic therapy. And of course, there was conflicting results regarding the benefits and the risk of each modality. Here is some advantage, the upside of using extracorporeal UF. You usually get greater fluid removal, about 1.4 liters, and better weight loss in a shorter time, lower chance of having advanced worsening congestive heart failure, acute decompensated heart failure, or chronic congestive heart failure, lower risk for rehospitalization, lower risk of electrolyte disturbances, and of course, there is no gain without pain. So all of these advantages could be limited by either the catheter placement insertion complication or because of the ultrafiltration, rapid fluid shift and removal would be associated with more hemodynamic instability and hypertension. Especially these patients are mostly have some kind of cardiogenic shock or at least hypertension. Of course, we have several ways to control the uremic milieu or the volume overload in our patients. We have several intermittent and also slow continuous therapies. And these therapies, we usually choose depending on, of course, the availability in our centers and ICU, and also because of the hemodynamic stability versus instability, the degree of uremia or kidney failure, and the need either for fluid removal or just if we need more clearance, more diffusion. So it depends which one we need. We need to remove fluid. If we need to do this, we can do a SCAF, which is a slow continuous ultrafiltration. If we need to do both, we can do CRRT. If there is really an urgency to improve the electrolyte imbalance or the acid-base disorder, we try to do intermittent HD. Of course, peritoneal dialysis is always an option for chronic therapy and also for acute therapy. And again, it's one of the slow continuous therapies. Again, if there's significant need for solid removal, we need to do intermittent HD, which is, rapid, the quickest way to improve the electrolyte imbalance. BERT, which is the prolonged intermittent renal replacement therapy, is a hybrid model between the continuous and the intermittent. and it's usually done for more than 6 hours. And we do this repeatedly over several days to remove fluids and also to do better solute clearance in hemodynamically unstable patients that we cannot do intermittent HD. Again, all of these modalities we use depending on our aim for the dialysis. Is it mainly for fluid removal? We do UF, whether intermittently or with the SCAF or CRRT, or it's only for correcting the acid-base disorder. So we need more diffusion and convection. The truth is, regardless of the modality of renal replacement therapy, sadly, still the mortality rate in cardio-renal syndrome is very high. It's about 70%. Hopefully, we can see some changes and improvement in these mortalities in the near future. Here are some updated references, 2023, 2024 references. If you need to read more, you can go ahead and read these articles. Okay, Edo, this is your turn now. Do you want to take this question?
Yes, of course. Thank you, Professor. Thank you for the opportunity to be here with you. So we need to find the wrong option in these 5 statements. So option A, the ultrafiltrate usually has less sodium concentration than the equivalent volume of urine. Extracorporeal UF fluid is isoosmolar. Ultrafiltration could be used as an adjunct for diuretic therapy in patients with cardio-renal syndrome. The rising serum creatinine with ultrafiltration doesn't necessarily indicate an adverse outcome. Or E, ultrafiltration doesn't usually induce neurohormonal activation compared to diuretic use. So going rapidly over these, extracorporeal UF fluid is isoosmolar by definition, being a plasma ultrafiltrate. C is definitely right and is linked to what we previously discussed. D is also correct, since it can almost be, let's say, expected to have an increase in creatinine, also just modifying the volume of distribution of creatinine itself. And so we're left with A and E, but I'd say A, since these patients are usually sodium avid, and being UF fluid is osmolar with plasma, ultrafiltrate usually has more sodium concentration than the equivalent volume of urine. So A would be my answer.
Very nice. I think that's a correct answer because actually when we remove fluids with the extracorporeal ultrafiltration, we remove also sodium because the ultrafiltrate is isoosmolar. But of course, the urine has much less amount of sodium compared to the UF. And again, this is one of the advantage because when you have more sodium in the body, it will collect and retain more fluid. So when you remove more sodium by ultrafiltration, you would expect also removal of more fluids. And of course, when you do this, if you are removing the same amount of fluid by using diuretics, you would anticipate that this patient may develop hypernatremia, kind of electrolyte imbalance because you remove more fluids than sodium. And again, this is not helpful because sodium retention is always bad for the heart, and also it will induce rebound increase of fluid overload after you de-escalate the use of diuretics. Of course, diuretics lead to more neurohormonal activation. So that's another drawback from using the diuretics. The other thing is when we do rapid fluid removal by extracorporeal UF, you decrease the renal tamponade. you decrease the renal compression by edema. So it's actually could be helpful to avoid the diuretic resistance, because initial diuretic resistance could happen because of the increased interglomerular tension by the edema, the interstitial edema, and the tamponading effect of this fluid retention. Of course, as we just said, there is differences between removing fluid by ultrafiltration compared to removing fluids by using aggressive diuretics. Of course, the hospital stay, you would anticipate that it will be less inpatient when we use the extracorporeal UF. The amount of diuresis will be higher. The venous congestion will be less with the UF, and there will be a rapid and adjustable decongestion, less neurohormonal activation with the extracorporeal UF. Some studies showed improvement of the quality of life. Of course, you decrease the polypharmacy, so you're not using a lot of diuretics, and you remove more sodium with ultrafiltration, and also you could improve cardiac remodeling and ventricular function by using extracorporeal UF. Again, some references if you are interested to read more and to get more knowledge about how to treat your patients with cardio-renal syndrome. Okay, Rania, that's your turn.
Yes. Can I? Okay. So which statement is incorrect regarding the use of peritoneal dialysis in cardio-renal syndrome? Answer A, peritoneal dialysis is a continuous kidney replacement modality that does not require anticoagulation or central venous access. This is partly correct. Okay, option B, peritoneal dialysis is effective in removing sodium. C, peritoneal dialysis helps to preserve the residual kidney function and to improve left ventricular ejection fraction. Just a minute. The last one. Something is not. Just a minute. Okay. The use of ecodextrine is associated with rapid fluid removal. Option E, peritoneal dialysis is a widely used modality in patients with acute cardio-renal syndrome. So I do not, actually, I do not have much experience with the peritoneal dialysis, but I do think we are going to choose the incorrect one. So peritoneal dialysis is a continuous kidney replacement therapy that does not require, this is correct, as I think. Peritoneal dialysis is effective in removing sodium. Actually, let us see. Peritoneal dialysis helps to preserve residual kidney function and improve LV ejection fraction. I know this is also, I don't, it's quite. Peritoneal dialysis is a widely used modality. I don't think that this is the incorrect. I think the incorrect one is the last one.
Very nice.
Yeah, this
you
is
are right.
exclusion.
So that's sad news, because we should actually encourage and try to implement more BD, which is a little bit safer way to control the volume and the uremia in patients both with acute and chronic cardio-renal syndrome. So again, BD is a continuous way of renal replacement therapy, and it doesn't require anticoagulation or central venous access. It's also has been proved that you can remove more fluids, especially if you're using concentrated glucose or icodextrin. You can have better weight loss, shorter hospital stay, lower risk of electrolyte disturbance, more sodium removal, and better preservation of the residual kidney function. It's very important because we know almost for fact now that BD can preserve or help to preserve the residual kidney function. You remember, even in patients on dialysis for a year or two, they still can make urine, they still have, low, but very important and crucial residual kidney function, and we need to preserve this. Also, in patients with acute cardio-renal syndrome, it's very important because they still can recover part of their kidney function. Icodextran is also a very good way. It's expensive, but it's a very good way to remove more fluids. It's not glucose-based solution, so actually it doesn't cause any problems with hyperglycemia. Also, it doesn't affect the permeability of the peritoneal membrane. If you see the statistics here from the ICU, patient with acute decompensated heart failure who needs dialysis, 60 to 80% of them will be on CRRT, 15 to 30 will be on intermittent hemodialysis. SLED and BERT constitute about 10 to 20%, isolated UF 10 to 30%, but the lowest is the use of peritoneal dialysis. So I think we need to encourage and to teach our team that this is a good way to control both the uremic status and the volume overload in our patient with cardio-renal syndrome, acute and chronic kidney disease as well. Here are some references if you want to read about the value of peritoneal dialysis in patients with cardio-renal syndrome. Edo, this is your turn.
Okay, so regarding extracorporeal ultrafiltration in cardio-renal syndrome patient, which statement is incorrect? So A, in AKI, a net ultrafiltration of 10 to 12 milliliters per kg per hour is considered safe. In chronic hemodialysis, UF rates of 6.8 to 10 mL per kg per hour are associated with a lower risk of mortality, and this, I am pretty sure it is true. Reducing dialysis temperature and increasing sodium help achieve UF, limiting hemodynamic instability, which is also true, especially in chronic hemodialysis patients. POCUS, VEXAS, hematocrit, and BMP are useful tools to guide UF, which seems reasonable, especially if used together. Aggressive UF can induce organ hypoperfusion and dysfunction, which is of course true. So we're left with A, which is also a higher target than in chronic hemodialysis patients. So it should be the incorrect statement for this scenario.
Very nice, very nice. That's the correct answer. So what would you be your target for fluid removal in the acute settings, Edo?
Well, it is a very difficult question since it depends for the patient. We have discussed previously that there is a sort of J-curve for safe ultrafiltration in AKI patients. So if I remember correctly, it was about 1 to 2 mL per kg per hour. So a lot less for continuous renal replacement therapy, of course.
Very correct, Edo. You're very smart. Thank you so much for this. So remember, in acute settings, we need to be more gentle. These patients are acutely sick, critically ill. They have mainly AKI, so we need also to preserve their kidney function. If we do aggressive fluid removal, the chances that they would recover their kidney function might be less. So a net UF of 1 to 1.75 ml per kg per hour is considered safe. So if the patient is 80 kilos or so, average 70 or 80 kilos patient, you can remove net fluid removal of about 100 ml per hour. So it will, sum up to about 2.4 liter a day, which should be enough. Maybe at the beginning, if the patient has severe volume overload and his hemodynamics is not bad, you can remove more. But maybe after 6 hours or so, just try to maintain this 1 to 1.75 ml per kg per hour to give the chance of the kidney to recover. In chronic settings, in patients on dialysis with end-stage kidney disease or advanced CKD, you can remove much more because they are probably more stable, and also the chances they are going to recover some of their kidney injury, or they are going to lose some of their residual kidney function will be less. So it could be at least 6-fold higher in your fluid removal. And instead of targeting 1 to 1.75, you can target about 7 to 10 ml per kg per hour. So of course, in HD and CRRT, we try to cool down the dialysate and also to decrease the sodium. Sometimes we do sequential UF, or also try to change the sodium settings to help to remove more fluids. UF could be reduced to avoid hypoperfusion state if the patient cannot tolerate the UF, of course. Here are some clinical and biomarkers that we use to guide our ultrafiltration. Of course, at the beginning, the patient might have some fluid retention, edema, crackles on chest exam. We have the in and out, so we can calculate how much the patient is volume overloaded, or how was the volume balance. Of course, more recently, we are using the book as the point of care ultrasound. You can get some information about the B lines, the EE ratio. If it is more than 15, that's usually associated with aggressive fluid overload. The VEXAS score, which is 1 to 3. So if it is 3, that's mean that this patient are significantly overloaded. If there is some pleural effusion or ascites, this would be also an indication for fluid overload. Of course, we are using also biomarker, especially the NT-proBNP, and you can also use the BNP. And we see the hemoglobin and the hematocrit, and also you can use other biomarker like the CA-125. So after removing fluids, after improving in the clinical status, you see that these clinical findings would improve. The BOCUS the B lines will disappear, A lines will appear, the EA ratio will be less than 10, VEXAS score will be 0 or 1, and the fluid in the pleural fluid or in the peritoneal fluid will disappear. The NT-proBNP will go at least 30% down. Hematocrit can go up about 8%. Hemoglobin will go up about 1 gram. CA-125 will go down to 35 or less. Of course, serum creatinine actually can go up, and we are calling it permissive hypercreatinemia. So the initial rise of serum creatinine in patients with acute decompensated heart failure is not usually a bad sign. It could be a good sign, and the long-term effect of this would be better, and this patient actually would have better outcome, especially with the renal recovery, and the hospital stay will be less, and the mortality will be less. Again, if you are interested, you can download these articles and read more about the cardio-renal syndrome. And I really thank you so much, Dr. Rania Omar and Dr. Edoardo Terzolo for trying to help us to answer this question today. And thank you so much. And we'll see you again in our webinars.